Thank you, Ali, and thank you very much, Flavia and colleagues at Norad, for putting this together, along with friends of all the other partner organizations. I'm coming from the state of Uttar Pradesh. Many people here may be familiar with the state which has actually the highest number of maternal deaths in all of India and probably bears responsibility for the global burden of maternal mortality. And I've had the privilege over the last 10 years to work with a grassroots organization of about 10,000 women from marginal social groups, which is called the Women's Health Rights Forum. In Hindi, the name is Mahila Swasthya Adhikar Manch, so I will refer to it as MSAM. And I've also worked with partners who are community-based groups of our network, the Health Watch Forum, which has been working to realize the right to health, including sexual and reproductive health in Uttar Pradesh for nearly 2 decades now. So since 2003, the women of these organizations, the MSAM and the Health Watch Forum, have been campaigning on the quality and availability of maternal health services in Uttar Pradesh, as well as the harassment with impunity for informal payments that they've been receiving at these health centers and extremely high out-of-pocket expenses that often force poor women to leave public health services and ricochet out into private services, which are also exorbitantly expensive. The government of India, to give credit, has actually tried to remove the financing barriers by giving a demand-side financing support called the Janani Suraksha Yojana, JSY, in 2005 that promised women something around like $21 if they attended institutions during labor, and has also removed all cost barriers in 2011 through the program called the Janani Shishu Suraksha Yojana that ensured free maternal and infant health services, including transportation. But unfortunately, we find in India today, our latest National Sample Survey organization shows that the average out-of-pocket expenditure for rural families for childbirth accessing either public or private facilities is something in the range of $80, which is just out of pocket. So it's like about 700 Norwegian kroner. So it's way more than what they're entitled to receive as a cash transfer. So this project that we did with the University of Columbia, the Averting Maternal Death and Disability Project, was trying to give women a tool to report informal payments, which would be confidential, and it would promote some kind of systemic improvements. And it was done across 2 districts of Uttar Pradesh involving about 40 health centers. The pilot was done in 2012 to 2013. We are now in the process of a scale-up in another few districts, which is ending next year. And we've been using mobile phones for women to use toll-free numbers to report to a website that uses the Ushahidi software to map exactly in which health center these kind of demands for informal payments are being taken, as well as providing an emergency hotline in case it's really a life and death situation. So I will not give you the details of the methodology and the evaluation, which is already in the paper, but just suffice it to say that we used heavily qualitative methods to assess the changes that were happening in terms of the relationships of accountability. And quantitatively, we measured the kind of calls that were being made, and we found that in the period of about 18 months, there were close to 900 calls made to this, and most of them were actually for amounts that were more than 70 to 100 kroner, or even more than that. And most of these were really money incurred on drugs, on tests, on transportation, and on food while staying at the hospitals. We also found that there was a kind of, let's say, benevolent support of the local health managers, but the kind of findings that we have, I'm just briefly going to share those in the next couple of minutes. The first thing is, although health managers were overtly supportive because we were coming in through a government channel to monitor the extent of informal payments, but they did not actually look at this website to see whether their own health centers were, on a real-time basis, we had the data to check whether their own health centers were actually taking money from the patients for these supposedly free services. And we also found that they only responded when emergency calls were made. There were about 31 calls across these 18 months. And when there were public demonstrations or public, state-citizen dialogues in which, improvements were demanded. So it could be that they were complicit or they were part of a chain that actually uses informal payments and corruption as a way of, amassing wealth for political. But it also indicates that health managers are not empowered to use data for local decision making, and data is most often fed upwards for someone up there to, make sense of it. We also found that in terms of the women's experience, women did not face a backlash, but definitely they were kind of marked out because people knew they would come with their, little pamphlet which had all the entitlements written, and people would know that, okay, these are informed users of health services and we cannot demand informal payments from them. But we also found that, of course, the money was not returned because just the, the reports were registered on the helpline. And then finally, it was that only the women of the MSAM group were actually still reporting because they had faith that change could occur with advocacy and campaigning. But women from other areas did not actually report in large numbers. So gradually also responses tapered off because the government was really not taking any significant recognition of the data. So what have we learned from this project? One of the things we learn about rights-based approaches is that users must know their entitlements in order to be able to claim them as social citizens. And they must be able to recognize a rights violation when it happens and have the means and the skills to actually report or register a grievance. And we also found that people need to be motivated to report because change will not occur immediately, but they need to have faith that change will occur in systems eventually, and they have to feel safe, so it needs to be confidential in terms of reporting. And finally, we feel that it's very significant that state actors actually respond to provide redress and remedy and guarantee non-repetition. We felt that research needs to be a partnership between the civil society movements and other campaigns on the ground that are actually trying to make rights-based approaches work, and research organizations that have the methodological rigor to bring out the results. And finally, I just want to close by saying that it is a challenge when we're talking of measuring rights-based approaches and their impact to look at these kind of iterative efforts, because the MSAM is an organization that's been working for nearly 10 years. And unless they were there, we actually wouldn't see the kind of results that we have from this particular helpline. And how do you measure empowerment? How do you measure shifts in state-society relations? Because ultimately, the right to health is actually predicated upon the way that citizens and the state interact with each other. It is implicated within those relationships of power. And how do you measure those? Thank you.
Thank you. Very good. Thank you.